off.
All right, that's working.
Hi, this is Larry Bauer, Chief Executive Officer Emeritus of the Family Medicine Education Consortium. And I'm very excited today that we will be able to present to you an innovation that I think is really brilliant. The innovation was created by Dr. Justin Schrager, an emergency room physician in the Atlanta, Georgia area. And we also have with us Dr. Uchenna Emeche, a family physician at the MedStar Franklin Square residency program in Baltimore, Maryland. And Justin, I'm going to turn things over to you.
Thank you, Larry. All right. So let me get my my slides up, and then I can show everyone presentation. All right. So as Larry said, my name is Justin Schrager. I'm an ER physician. I have worked at Emory for almost 10 years and did all my training there, but I have recently moved and I'll be working in IU for the coming foreseeable future and starting in August. So Indiana, which is an interesting thing for my family to move up there. And so I'm going to show you the some very brief slides and then demonstration of the software platform. And I think that the reason that Larry invited me to present to you is that we built a software platform, myself and my co-founder and our company, which is called Vital Software, which engages with patients in the acute care setting, particularly in the emergency department, but also in the inpatient setting. And one of the main purposes of what we do is giving patients an idea of what's going on, helping them understand their care journey, educate them, communicate with them, take workload off of the staff that's in the building, in the hospital, particularly our overworked ER nurses and technicians, physicians, of course. And then we also talk with patients a lot about what they're going to do when they leave to go home. Most ER patients are discharged home. About 15% of patients are admitted on average, but most go home. Most are asked to follow up in primary care clinics like yours and or with specialists. So we do a lot of work helping patients understand what their next steps are. So, you know, Vital Software is a venture-backed startup. We are very deeply involved in a user, sort of like a consumer-based experience, consumer-grade software. We do a lot of things with artificial intelligence, which I'll get into. And our buyers for this platform are health systems and hospitals. So they pay us for the service, and it's a SaaS, software as a service, and then their patients can use it. So like I mentioned, we do a lot of artificial intelligence, which I realize is a buzzword and it comes up all the time, but we actually do use it for a variety of things within the platform. Everything from predicting wait times for people in the emergency department waiting room to directing them to AI-based educational content, kind of like YouTube would direct you to videos that might be interesting to you. And then we also use the more newer natural language processing techniques, large language models, to translate physician notes and results into things that patients can read at the bedside. So what we're trying to do with all of this is to enhance communication, tell people what they want to know when they need it, and then decrease the amount of back and forth you have with patients. You know, I understand this is in the hospital setting, but a lot of this translates to what people do when they leave the emergency department, how well they're informed of what they're supposed to be doing, how they're supposed to seek, achieve, and follow up with their primary care doctors or the specialist that was recommended to them. And it all comes down to how we talk to patients. So we pride ourselves in talking to patients. And so as you can see, the company itself has grown quite a bit in the last 6 years. The way we talk to patients is it's very personal. So when you're in the hospital, we'll say things to you like, "Hi, Justin, your chest x-ray is just completed. Would you like to read it?" Or, you know, when we reach out to people and their family members within the application, it's very directed to specific needs at specific times. Like, Would you like to follow along with your grandmother's ER visit? She's currently in the waiting room and things like that. So we do that. And what happens because of it is we wind up with very high utilization. And the utilization in and of itself is, and can someone on the call, can you tell me if you can see the phone screen there? Okay, cool. So what we do is we make it extremely easy for patients to access this information that I was mentioning. And so because of that, we have about, in an average hospital and that emergency department, we have about 2/3 of all the patients using the platform. That includes people logging in at the beginning of their visit to see their wait times, which you can see here, following along during their visit to see the labs and imaging, at the end of the visit for obtaining follow-up appointments and things like that. And then we also have about as many people that are not in the hospital following along. So as you'll see, patients can share this visit with their loved ones that are not there. So for example, like if your family member was in the hospital across the country and you wanted to know what was going on and nobody was telling you or calling you, you could see a lot of the information that would be conveyed to you, like they're in room 314 or they're waiting for their CAT scan, things like that. So our onboarding process for the hospital is different than what you've probably seen in healthcare software. So we do unique secure links to patients. They only go out after the registration process. So what we really need for the hospital to do is to give us a phone number to message. But we already know the patient's there. The registration staff have been trained to collect and verify demographic information. And so once they input that information into the electronic health record, we pull it out of the EHR. We pull all kinds of stuff out of the EHR, but this is the first thing that we pull out. And so we'll message the patient and then they can log in. Now this is what's called a white label solution. So basically the hospital will have their logo and colors and everything on this. This is just a demo. But one of the things we do to make things easy for the patient is we use the native language within their web browser. So this works off Google Chrome or Safari or whatever Firefox that they have on their phone. And if they typically read the internet, engage with the internet in Spanish, we will know that automatically, and all of this content will be automatically translated for them. And we can do that in multiple languages, not just Spanish, but we typically see the most utilization in Spanish. The patient then has to verify their last name and their date of birth to get into the application. There's a lot in here, and I'm going to go through it quickly out of respect for your time. But, what I want you to take away from this is that if you were a patient sitting in the emergency department and you didn't know what was happening, well, you go and check in and have a wristband put on and you log into this application, you don't know what's happening next. Most people don't go to the emergency department very frequently, a few times in their life. There are, of course, people that go very frequently and they know how it works, but most people don't. They don't know what triage is. They don't know why they're waiting. They don't know why the person that checked in after them got to go back first, things like that. So what we're trying to do is provide them context, information about where they are, and then we provide that context to them when they need. So in this case, this patient's checked in. They're waiting to be seen by a triage nurse. We know about how busy it is that day, which you can see on this graph. And we use AI in the same way that Google Maps uses it to calculate your time to drive to work, to give the patient an estimate of how long they're going to wait. This is adjusted for sort of the throughput of the department overall, and it's also adjusted for their own unique demographic details. So if two people check in simultaneously and one of them is more sick or one is elderly, their wait time is going to be different than the other one. So the wait time we estimate for this patient is actually 15 minutes in this case, and the 30-minute thing that you're seeing here is actually 90th percentile confidence interval in the estimate. So the vast majority of patients, actually about 92% of patients, will receive a triage assessment within this time limit, which is how we design it. It's very advanced math, but it comes across as a fairly simple thing that the patients can see. We have lots of information in this application, and we break the ER visit down for the patient, arrival to triage, their wait time, after they've been placed into a room and they're waiting to see a physician. And then once their workup is done, and then of course, after they've been admitted or discharged, there's some more information there. Every section has its own information. Every section has content that they can read. We have some really cool videos that patients can read. I'm not going to click on this out of the, respect for your time, but they're just kind of like medical videos about why you have to wait in the emergency department waiting room. We have some fun tips that my nurse friends wrote, doctor friends, just help with operational efficiency in the department. No, so this patient has already gone through triage. Now they're waiting for a room. And so they get a different time estimate. This is how long you're going to be in the waiting room. They're classic, how long am I going to be out here? There are some more things in this part of the application. There's some redundancy because we have people logging in before triage, after they've been placed into a room. And we kind of don't care when they log in. We'll just move them forward in the experience automatically based on what's happening in the EHR. In this case, I'm going to show you this visit sharing. So the patients can share their visit with anyone they want, but if they click the sharing button, we'll bring up the native text message platform in their phone, and they can pick someone they want to send it to. We'll write the text message for them and give information about the hospital. And then the person who's not there can follow along. And you can do this any number of times. So for example, like I mentioned earlier, you could follow along with your family member's ER visit if you're in California and they're in New York, you can see what's going on. You can see they're in the waiting room. They're having some tests ordered. You can see who their doctor is, if an attending is signed up, and just some basic demographics, sort of information about the facility. The other things that happen at this point is you might be assigned a physician. So maybe a doctor signed up to see you, but you haven't been brought to a room yet. We start talking to patients about finding a doctor. So, believe it or not, most patients that come to the emergency department, about 80% of them either don't have a PCP or don't know who their PCP is, or it's not listed in the EHR. So the numbers and the data on it are awful, actually. And so one of the things that we do for the hospitals and for patients is to try and engage them early to help them with this process. So some hospitals will actually send a caseworker down to the ER to help a patient that doesn't have a PCP make an appointment. And we have scheduling systems that are built into the back end, which I can show you if we have time. We have demographic details, and then we have something called service requests, which is, think of it like a call button for the waiting room. You can click these things and it goes through to staff members. Now, this is the only thing in the application that the staff need to do anything for. I'm not going to get into it too much, but it's essentially a flexible system to put anything you want in these boxes. And we can redirect if a patient pushes a button in the waiting room, we can send it to anyone you want in the building. So it works through web browser or smartphone. It's a very simple system, but it's very popular in the ER where things are a little more chaotic, and it's not as prescribed as on the floor where each nurse has X number of rooms and so on and so forth. So if you have tests ordered, we will show you the tests in the application. The tests come across as a name, which we have translated from whatever comes across from the electronic health record. It's a little messy, but we normalize it and show patients that they have these tests ordered. These are ordered, some are completed, some are canceled. If the patient wants to, they can click on it and read what their results are. Now, the first thing we don't show them is a number. We actually show them context. This comes from the lab. And there's educational content sort of surrounding it like a donut. So it's kind of hard to get your abnormal result without reading or learning about the test itself. And that content comes from freely available libraries. Essentially, what we're trying to do here is to educate patients without, sort of bringing on frustrating questions or concerns that they, clinically we may not be as concerned about, right? So the classic joke when patients go into their patient portal while they're sitting in the waiting room in the ER is that they learn that their RDW value is a little high, or they have a sorbic acid in their urine or something like that, which we all know is like kind of usually not that important in the clinical context, but patients get concerned about those things. So we typically will try to explain them. There are a number of other things that people can do in here, but imagine yourself sitting in the ER, and then as you are physically moved from the waiting room to a room, we then update your stage of the care journey. In this case, you're waiting for your results and everything to finish in the department. We'll give you an estimate for that. We start talking to you about what's going to happen at the end of your visit. Of course, there's the imaging results and everything in here as well. And a lot of redundancy, as I showed you before, but for that reason, I mean, the patients log in at different times during their visit. Whether they come in an ambulance and go right into a room, they'll log in and they'll see this. Whereas if you walk in, you may have to wait, or if you do wait. We have a fairly detailed discharge, we call it discharge summary, but it's basically a new digital version of that packet of paper that all the patients get handed at the end of the visit. Only this is a little bit more, let's say, content rich and directed towards what we want people to do. So we have read your care instructions, right? So we have the ability to put this forward. These are things that the physician has written. We have schedule a follow-up visit. What we're actually doing is using AI to read physician notes. And you can see at the end of the ER doctor's note or the discharge paperwork that I want, you can see right here, a specialist and a PCP. In this case, the patient has a broken leg, I think. And the ER doctor has said, I want you to follow up with your PCP. We do have that information, and we'll tell the patient how long it is. And you can see the contact information right here. And then we also have a specialist. So the ER doctor said, you need to see an orthopedist. Well, any orthopedist. They didn't name who it was. They said, find an orthopedist. So if you actually click on it, we have our own, let's say, network. It's essentially like a Find a Doc, which you may have seen out there. But we can pre-sort it based on characteristics of the patient, how far they live from the doctor, if insurance are accepted, do they translate, or do they speak multiple languages, do they have high quality care. We have different integrations from different, say, cost and quality networks, so we know things about physicians for better or worse, but these are things patients want to know about, ratings. And if the patient wants to make an appointment with, like, Selena Schwartz, orthopedist, they can click here. They can kind of pick generally when it's supposed to happen. We know the time frame and send a request. I won't dig into this too much, but as a physician or an office manager or someone in your office, you would receive messages from us saying which patients want an appointment, what the appointment is, and you can asynchronously communicate back and forth with them to help set that up within whatever scheduling system you use. Obviously, the big things we want people to understand their discharge instructions. We want them to make appointments, right? So like if you look in here, this is a kind of a mock-up, but what you saw originally was the physician's note. This is our designers kind of mushed it down. This is like an orthopedic surgeon's note. But if you actually click the system, we actually will translate it for patients using AI. So we'll tell the patient what the doctor wrote in their note in a patient-friendly way and translate some jargon and things like that. So it's a really cool new use of the large language models, which I think is very useful to help explain things to patients. I think most of this is self-explanatory. We'll tell people where their meds are, get them back into the portal. We have diagnostic videos. I'm not sure why a person with a hip fracture would be discharged from the ER, but I think this is an inpatient demo and other things like that. So you can see how it might be useful, I think, probably in the primary care setting, because you can actually take all this data that's here, share it with family members, and if you want, you can send it to your PCP. This is good for unaffiliated, unemployed primary care, not unemployed, not health system employed physicians to sort of link care together. We also have the capacity to send patients messages. So even if they're not logged into our app, even if they're not on a modern phone, right? If they have a flip phone, we can send them messages. And we can send lots of different kinds of messages. And this is something that I think is very valuable from a cost containment standpoint, especially if you take care of a lot of capitated patients who are financially at risk on. We can send messages to patients based on pre-existing criteria. So, are you a member of an ACO? Well, your ACO care coordinator actually wants you to like call this phone number instead of just going to the random orthopedist that the ER doctor told you to see. Or if you're, like if you contract with MA and they want your patients to have follow-up visits within a week after an ER discharge, we can ingest lists of those patients, the ones that you're at risk for, and then send them special messages at the end. It's actually a fairly easy thing to do, but the real special sauce here is that, like I said earlier, about 2/3 of the patients in the hospital are using this application to do things they want to do, share with their families, see their results, like look at their imaging studies and see their wait times and stuff like that. And so the flip side of it is as healthcare providers, we can actually, or I guess as a software system using this piece of software, we can actually show patients things that are beneficial to them in terms of getting follow-up, making sure they know where they're supposed to go. And then if there are cost containment strategies that the primary care physician or the health system is involved in, and it will benefit the health system, of course, to decrease overall cost on the capitated patients or at-risk patients. It also helps the patients, because what they do now is they get on the phone and they wind up in this like death spiral of calling 42 different specialists and doctors around town to try and obtain follow-up, and just to find out they're not accepted or they're busy or whatever. So we spend a lot of time on that. The whole systems like our platform for a variety of reasons. We do improve their HCAP scores. We have shown improvements in the left without being seen rates in the emergency department, something we care about. In the ED particularly, we have improvements in follow-up, obtaining, specialty follow-up after leaving the department, all the stuff that I've talked about, and a few other things like that. So like that's the software platform in a nutshell. I can give you a little bit more in depth into the sort of messaging platform of care coordinators out of hospital, care coordinators in hospital, care coordinators, social work, that kind of thing if you want. But I just wanted to kind of give you a high level rundown of what the software system looks like right now. So again, thanks for your time.
Uchenna, I know you have a time issue. Did you have a question or a comment that you wanted to make?
Just a question, I guess it's a question/comment. So is your company looking to be acquired by one of either the EMR companies or maybe by a large hospital system? It's just like
No, not really.
Acquisition, it sounds like.
Yeah, that's a good question. It's funny, and I think somewhat validating, since we've reached the size that we have now. We just over the last month got to the point where we have 1 million patients using it per year, which is something I'm very proud of, because it's been a long road. But Aaron Patzer is my co-founder, and I are not interested in selling it. We want to just keep growing it. I think that, well, so Aaron has been successful in tech entrepreneurship in the past. He was the founder of Mint.com, which is a personal finance website that you may or may not have heard of. It was acquired by Intuit. And he really just liked building product and being innovative and doing this kind of thing, which is what I like to do. So we actually didn't get into this to try and build something that we would sell. We actually got into it because we were sick of what was out there in the healthcare world. And there was a whole vacancy for this type of thing. And actually, when we first started, a lot of what we were doing was operational clinical decision support, say operational support for hospitals, using AI to predict wait times for patients. It's sort of a knock-on of the pandemic. Actually, we shifted a bit. But what we were originally doing was predicting admission, so the hospital could get beds ready ahead of time, predicting criticality, some sort of like nurse intensity index and things like that, that I think were pretty cool. We're still working on those things, but I would say the platform or the piece of software that's been the most successful is the patient engagement platform. And it, in the emergency department, it's really easy to build something like this because the EHRs and hospitals haven't spent a lot of time on digital solutions for patients in the emergency department. That even includes the big EHR vendors. They have very little for patients in the ER. And, you know, there is, of course, my chart, and people can log into their portal and Cerner and Epic, but isn't really like for the ER. It's more for clinic patients and things like that. So we felt that that was a good space. And we, of course, have expanded our platform into the hospital. So now there is, we have something like what you've seen, but for inpatients and OR and labor and delivery and things. And so to that extent, we are sort of butting up against some of the Epic offerings, I guess, from a competitive standpoint. Not that I would say our company is directly competing with Epic right now. We try to work with them. But I would say the one thing that we have that none of these other people have is that there are so many patients using it. If you look at the big EHRs, including Epic, you know, you're only at like 5 to 10% of the patients are using their portal or their bedside platform because it's just so hard to use. They're having to download things and usernames and passwords, and nurses have to kind of like help the patients do it. Whereas ours is pretty easy to use. In fact, it's designed to not bother the staff. So everything we do is geared towards, can we take something off a nurse's plate? Can we decrease a nurse going into the room to help the patient order food or turn down the temperature or something like that?
So Justin, one of the things that attracted me about this, that you've sort of alluded to, but not directly commented on, is I see an opportunity here if a patient has a primary care physician,
Yep.
and they know the person's name, which I do appreciate. It's surprising, but some people can't pull that out, particularly situation going to the emergency room. And but if they wanted to engage, or if the system wanted to bring the general internist and family physicians in so that their knowledge from their continuity of experience with the patient could be brought in to the ER doc, to the decision making, I see your platform providing that the gateway for that to happen. Could you comment on that?
Yeah, so actually to be perfectly frank, one of the hardest things to do in healthcare software is to get physicians to use it. Not that physicians are dinosaurs or anything like that, but it's just like asynchronous communication between physicians is actually very hard to do. And if you actually look at the demographic split of how emergency visits occur, about 2/3 of them occur after hours and in the middle of the night. So what we've done actually is tried to communicate with the people that make, sort of the, I guess, operational decision making for physicians, physician groups a little bit better first. So messaging, we've worked with organizations that have social workers in the community that are geared towards Medicaid patients. We will message those social workers directly so that they can come and help the patient if they need it right after they check in. We have, obviously, I showed you a little bit about messaging care coordinators when patients need a specific type of follow-up, either in the hospital or in the clinic, or nurses in the clinic. So we will send those messages asynchronously. As far as bringing doctors like my dad into the bedside with me, as much as that would be my dream, we haven't done that yet. But it's actually fairly easy if we knew which patients were attributed to which PCP. The real problem is that the EHR data is garbage. It's absolute garbage, especially if you're in a health system that is not completely employed, right? So if you are not let's say, for example, Kaiser, right? So those patients, they are assigned to a primary care doctor. That doctor is part of the same employment group. And it kind of doesn't matter whether the patient remembers their doctor's name or not, which is that, or if the registration staff have the time to really delve into who the PCP is with the patient, recheck the data. Like, hey, we have Dr. Schrager as your primary care doctor. Is that still true? Did you see him? Or that kind of thing. So actually the data in the EHR is really bad for a variety of reasons, both because patients can't remember and the hospital system doesn't put a lot of effort into keeping track of it correctly, right? However, if we have that data, or if we can ask the patient to update it or help them search through it, we can actually asynchronously message anyone within our network. So like, let's say, Larry, if you were a primary care doctor and your patient came to the ER, and you were a user of our software platform, meaning we onboarded you either by email or phone, we could message you right then and say, your patient literally just checked in at the front desk of the ER. We would just need to know whose patient you are. And we've done that with one primary care group in Atlanta. So the second one of their patients check in, we message one of the nurses in their office. And that nurse sort of is the phone nurse, I guess, so to
Right.
speak, is the one who answers most of the refills and clinical questions and stuff like that. So we message her by text message and say, hey, one of your patients just checked into this emergency department. And so they use that to call the patient. They can message the patient in our app. They can tell the patient to call this number when they have time, or they can actually see who's taking care of the patient in the ER and what the phone number is there. So if you wanted to call. So it's actually pretty easy to do that kind of thing. And what it just requires is the primary care physician or their extended network or their group to tell us which patients are theirs.
Right.
So
you've created the platform, and if the financial incentives were right, so that the primary care physicians would say to each patient as part of their onboarding of their welcoming of their patients coming into the practice, we really want you to know if you get really sick, particularly for high risk people, if you get sick and end up in the emergency room, here's how we'll be involved in your care, and really coaching the patients, perhaps even giving them a special card that says
all this number.
If the financial incentives were right, you've created the structure which would allow that to happen.
Yes, and that's the most important thing is that we've done this a couple times with varying degrees of success depending on the organization's need. And the disconnect there is that patients don't have information on their insurance card that says that they are part of a capitated plan or an MA, or if they're an ACO patient. It actually just kind of says what kind of insurance they have. And so there's no way and many patients don't even know, right? They just signed up for the thing that came in the mail. They don't really understand how it works, right? So what we do to solve that problem is we take in lists of patients that you care about. And frankly, I don't decide that. So if I work with the billing office at a health system, they say, hey, these two MA plans are making us get follow-up appointments for people with 2 chronic conditions that fill in this list, CHF, COPD, within a week. And we are failing to meet that need, right? And so we're at financial risk to do that, but we know who those patients are. So if those people check into the ER, we want to tell them 2 things. Call this number, because we have a social worker or a care coordinator waiting. But you understand how it works, but it's basically we're promoting information to the patients that is in their financial best interest, help them get linked back into care, but also helps their primary care group or their physician group sort of prevent cost. As an ER doctor, I'm the main driver of a lot of this cost. And of course, much of it is not inevitable if you can just reach the patient ahead of time, or at least involve yourself in their care as they go, whether it's preventing unnecessary care while they're in the ED, or possibly decreasing their length of stay, or making sure they go to the appropriate post-acute care facility, or whatever it is. It's just like an extra helping hand. And of course, you would extend that helping hand if it was going to help you with your contracting, help you with your bonuses at the end of the year for capitated patients, or if they're just patients that you are particularly worried about because of your type practice style or whatever it happens to be. It doesn't have to be just for cost containment for insurance. It could be literally anything. It's important to you. So and then the messaging is configurable. It's configurable based on time of day, things like that. So can do all that. And then, of course, as I mentioned, we can reach out to you or your staff members when those patients check in and tell you things about them. So
Well, I think that's great. I'm not sure if Uchenna is still with us. She had to
She has
Had to
to
do some-
precept her residence, but
Yeah.
I'm sure she'll have questions. There's a lot of questions that always come up in this platform, so please, Larry, if you don't mind, make my information available. I'm more than
Sure,
happy
I would be
to-
I would be happy to do that. So, Dr. Schrager, thank you so much for this presentation. And I'm going to bring things to close right now. And so thank you very much.
And thank you.